So thank you for joining our dialogue and an update for our different project partners on our CIHR funded project, establishing a more inclusive and integrated health workforce minimum data standard that's purpose-built for planning and enhanced decision-making. So I want to acknowledge that we are joining everybody across a variety of different territories. I'm joining from just outside of Ottawa, still is unceded, unsurrendered territory of the Algonquin Anishinaabe First Nations. And in introducing yourself, please take the opportunity to acknowledge where you are coming from. Now, it's important to note that we recognize that land acknowledgements are really only one small part of disrupting the erasure of Indigenous cultures and dismantling colonial structures, of which universities are very much a part of that. And we are explicitly working in this project to help respond to the Truth and Reconciliation Commission calls to action to increase the complement of Indigenous health workers. And we're doing that through actually measuring the number of Indigenous health workers that we have, being very mindful and respectful of Indigenous data sovereignty, and I'll be speaking to that later on in one of the slides. So just to give you an overview, we want to reiterate the rationale for our CIHR-funded Health Workforce Minimum Data Standard development project. We want to discuss with you the latest version of the architecture and the draft data elements that have been informed through a number of demonstration projects. We had 2 demonstration project partners report on the 18th from the Ontario Medical Association and from a number of physiotherapy regulators. And we're very, very pleased to be joined by Kelly Dobbin of the Canadian Midwifery Regulators Consortium and Adam Schoenberg, who represents regulators for medical laboratory technology professionals. And we also want to discuss progress towards the development of guidance for implementation, including, but not only exclusively, for Indigenous data sovereignty. So first of all, why do we need a health workforce minimum data standard? What's the rationale for that? And those of you who know us at the Canadian Health Workforce Network know that we've been doing a variety of different types of projects. And it has become really clear through the research that we are doing that one really important foundational limitation that we have in Canada is the lack of standardized data across professions. And that makes it very difficult for us to do integrated health workforce planning. So it's important to highlight that there are broader global governance mechanisms that we have signed on to, one of which is the Global Code of Practice on the International Recruitment of Health Personnel that Canada has signed on to, in addition to all other WHO member nations. There are 2 important guiding principles in this global code that are often ignored. Countries are encouraged to strengthen health workforce data gathering, and that they should implement effective health workforce planning, development, and sustainability strategies. This has been suboptimal in Canada, and some people might say almost completely absent. So in a brief that we prepared on behalf of the Canadian Health Workforce Network, we talked about strategic investments in 3 key elements which will improve data infrastructures, bolster knowledge creation, and inform decision-making activities. And at the foundation of this was an enhanced health workforce minimum data standard for planning and inclusive data collection. The better data that we have, the more informative, timely, accessible, interaction, fit for purpose decision support tools such as dashboards, especially interactive dashboards that are sector focused and cut across a number of different health professions. And then we also have to build capacity in utilizing those tools and analyzing those data, because if you build data and you don't build the capacity to utilize those data, they will be again suboptimally utilized. And so it's really important. This is a diagram from a colleague of mine at one of the Centers for Health Workforce Studies in the United States about really what is the purpose of planning, is to really limit this excessive, moving between shortages and surpluses. We want to attenuate the amplitude of this particular thing. We're never going to get it completely flat, but if we can get it closer to flat, that would be better. So planning enables you to intervene earlier and to make decisions, and also projecting, future states based on a variety of different scenarios. So that's really the state of the science in this area. And again, foundational to that is a health workforce minimum data standard. So right now, we know that health workforce planning is urgently needed to address health system challenges. As we say, the best time to have planned would have been 20 years ago, but the next best time is now. So let's get that in place. Challenges that we need to meet and that need to address in order to move this forward is that the health workforce data landscape in Canada is very fragmented, and it's the data are siloed by occupation or profession and jurisdiction with very limited common data elements. In most cases, the data are only available at the aggregate level. They would include age, gender as a binary province, and that is absolutely insufficient for health workforce planning purposes. The data that we do have doesn't cover certain health workforces, and there's little information about the diversity of the health workforce, and measured in a way that's much more sensitive to different issues around data governance. And this, as a result, this data pathway is very time and resource intensive due to the lack of standardization. So I want you to be mindful that when you're looking at what are the data elements that we are including in our minimum data standard, we are mindful of data collection burden, but the situation right now is the most burdensome because there are survey after survey after survey that are done and very little opportunity to connect them and link them because of the lack of standardization. So our response is a partnered research approach, peer-reviewed by the Canadian Institute of Health Research, and competitively funded. This is not a strategic funding initiative. And it is a partnered research project to co-develop a fit-for-purpose health workforce minimum data standard that supports planning and health workforce decision-making. It draws upon existing minimum data standards, not only in Canada, but internationally, because we have reporting to do internationally. And we all know that there's a bit of a permeable boundary between us and the United States. So it would be mindful for us to have a similar data standard as the United States. This is to be evidence-informed data elements. Each data element in our minimum data standard has some link to literature showing that this is an important data element for health workforce planning. It also is evidence-informed in terms of the collection and stewardship considerations. It is purpose-built to be applicable across professions and jurisdictions, and we have 11 case studies, but we are purposely building this to be applicable across more than just those 11 case studies. The 11 case studies were purposely chosen because they represent a variety of different circumstances that we wanted to explicitly take into consideration in the development. We are integrating partner feedback through practitioner-specific studies and demonstration projects, but we are also interested in undertaking demonstration projects that are multi-professional, jurisdiction-focused. And really, really importantly, this minimum data standard will be available completely open access without any need for a license or without any fees. So we want this to be used. We're really about, utilizing the data at the end for planning purposes. So it's important to distinguish what this project is about. We are developing a minimum data standard. That's a set of questions or data elements. It's similar to developing a survey. That is what we're doing. We are not creating a minimum data set. That is the responses to those questions. It's not what our project is doing, but we are very interested in supporting our partners to take this and create data sets moving forward. And we can have a conversation in that regard. So just by way of overview, we are in the third phase of this project. We have co-developed with an MDS with many partners, and it's still not completely closed because we're still listening to our demonstration project partners and the feedback that they'll provide. We have done an extensive review across different jurisdictions of the legal context for adoption of a minimum data standard. And we are really looking forward to developing, with your feedback, some technical guidance of the adoption. We are undertaking practitioner-specific demonstration projects, two of whom will be reporting here. And then we really want to develop tools to spread and scale. that's ultimately what we want to do. So the current health workforce data landscape in Canada informed our choices of case studies. So it really was based on the relative strength of data collection and reporting. And although we've clustered them along this dimension of strength, it's important to note that there are silos within each of those. So personal care work, or the 20 different ways that they are referred to across Canada. The low amount of data or low strength of data for midwifery and medical laboratory technology will be discussed by Kelly and Adam. And medicine, nursing, occupational therapy, pharmacy, and physiotherapy have more moderate data, but I wouldn't say that they are excellent. And we really have to aspire to greater excellence. And so in green are our demonstration project partners. Medicine and physiotherapy reported on last week, and we are going to be posting those if you'd like to know a little bit more about those projects. So briefly, our modular architecture has core and enhanced data elements. This exists within an Excel file that lists questions, the response categories, implementation considerations, and issues around whether or not these data need to be collected by from a registry, sort of for all health workers, or is a sample through a survey, more appropriate, or could it be done in that way? Because again, we can utilize both data on the entire population of workers, and we can utilize data from a survey for planning purposes. So there are 3 modules. We start first with the employment and service capacity module. We have an education module, and then our 3rd module is around identification and demographics. So I'm going to walk through each of these. So on this slide, what is in sort of this middle column, with A and B, is what the core data elements are, and in the separate column is our consideration for enhanced data elements. So for the capacity module, we would be measuring this for up to 90% of one's activities, or if someone is just in one position, they would only have to do this once. But if people are in multiple positions, we want to capture the full spectrum of their capacity. We feel that that's very important. So there are 2 submodules, employment practice submodule or the service capacity submodule, and we're really trying to use language that's inclusive of different work circumstances. So we're looking at employment status. Are they employed, not employed? In what position are they employed in? And we are going to map that to the National Occupational Codes. We know that there's a bit of misalignment for some professions on the National Occupational Codes, and we feel that this would make that clearer. And we are in conversations with folks that head up the National Occupational Codes about an intent to be much more aligned to the categories, the regulated categories. We're looking at organization or practice name, location through postal code, or if it's outside of Canada. And we're trying to get at some proximity of sector and area of practice that enables us to get at just a little bit at scope of practice. That's a bigger chunk. We're thinking about developing a scope of practice module later. And again, designing this in a very modular manner, and that enables us to add different dimensions to that. In an enhanced module, we would want to know the reasons not employed, and we would want to get a sense of role title. But we really want to, again, be standardized right from the outset. So mapping this to the National Occupational Code is really important. Now, what's really a unique and value add component to our minimum data standard that doesn't exist for any minimum data standard is our approach to measuring service capacity. And so what we do is we take a total time in sort of hours per week and weeks per year, and in different types of modality. So in our core module, we ask for total time and how much of that is in direct care. And we also want, and this was an additional dimension from partner feedback, that what is that provision of direct care that's paid or unpaid overtime. In the enhanced module, we would get at whether or not direct care was being provided in a supervisory role, what other activities were being undertaken in terms of teaching, research, administration, or other. And some of that would be by different modality, And again, with the same measure of hours per week, weeks per year on average. We would also ask about employment preferences in the enhanced module because we know that that is something that we would want to model. And then we have also added from partner feedback, self-rated mental health and burnout. Now, it's important to note that although we've added these dimensions, they're in the minimum data standard, it doesn't mean that all organizations have to collect all of this data. So for example, self-rated mental health and burnout may not be appropriate for regulatory authorities to collect. That may be something that could be undertaken in a survey capacity from associations and unions. So it's important to know that this is the data standard. A variety of different organizations can collect different elements of it. It's not an all or none. It's just we've identified that these would be important elements. What would be exceptional, knowing that there is a huge literature on mental health and burnout, is if there was at least some alignment to the measures that were utilized, because there's a variety of different measures that are utilized presently. Okay, so that's module number 1. That's the really important one about measuring capacity so that we could do workforce planning. Module 2 is about developing, what are the skills that you have to deliver on that capacity. And unfortunately, it's not up to 90% of activities, it's just your education. So we have core training and training for enhanced roles. Core training is the training that you need to be a midwife, a medical laboratory technologist. If you've trained for enhanced roles, then we want to capture that, because if you have training for enhanced roles, are you able to do that in your capacity? Are you optimizing that enhanced scope in the work that you're doing? So again, really important considerations for planning. So we're looking at level, we're looking at specialization, if that's relevant for your profession, and in some cases it's not, institution and completion date. And then the same type of information for enhanced roles, which may also include expiration date. So we want to do that. In an enhanced module, we want to get at language of training. And if these are if you're internationally educated, have you undertaken any bridge training? And we've also added recruitment pathway. And this comes from work that we've been commissioned to do on behalf of the WHO that's looking at the WHO code, which is why I sort of started with that, about recruitment pathway, because there's actually a paucity of data of how internationally educated health practitioners came into various countries. So we figured that we should add that to our minimum data standard. That would really be an international advance. And then training for enhanced roles, are you qualified to train others? Now, it's important to notice the type of bullets that we're using. Like in this slide, we have square bullets, and that indicates tombstone data. So these are data that we can pull together into an algorithm to create a unique identifier, which is what we'll get to on the next slide. If you do not have a unique identifier, utilizing these data to add to an algorithm to develop a unique identifier will be really important to ensure that people are registered across multiple jurisdictions, they're not being double counted, or if people are registered in a couple of different professions, that they are not double counted. All right, module 3 includes a registration or identification submodule and a demographic submodule. And so as we've identified here, a unique identifier, which could be an existing identifier, one could use social insurance number. Other countries have utilized the equivalent of social insurance number, and social insurance number has been utilized in some jurisdictions. For example, our partners in British Columbia have mentioned that, and so they encouraged us to add that as an option for a unique identifier. Another way to create a unique identifier is through an algorithm by including these tombstone data elements, and that's why we've put name in the enhanced one. We would not need name if you have a unique identifier or chose social insurance number. Initial registration, path issuing institution, again, tombstone data that we wouldn't need. These are what we are going to be asking to create a unique identifier. You would have registration number, status, and the issuing institution in the past 12 months. So that's the registration module. For a number of our demonstration project partners who are regulators, they are interested in a separate regulation module, which we are developing. It's not for planning purposes. It is something that we are sharing with our demonstration project partners, a bit as a quid pro quo, to thank them for developing that, because they would also like a standardized approach to how to capture data. That's from a regulatory perspective. We would not need those data for planning. So it's going to be a separate module. Okay, parking that. In our demographics submodule, we would be asking date of birth. We would be looking at gender identity. And again, in a non-binary way, we would ask non-binary options as an enhanced data element. We have issues around race, national or ethnic identity. Right now, we are drawing upon an exemplar from the Racism in Nursing Survey, because even the stats can question conflates race, which is really a social construct, national origin, and ethnic identity. So you have Black and Filipino as response categories in the stats can question. So we've utilized the Racism in Nursing Survey, which draws that out in much more precision. Looking at Indigenous identity. And so some of these elements with the plus, these are requirements under federal employment equity legislation, but we would want to, in a minimum data standard that's applicable across Canada, be in alignment with employment equity. Indigenous identity would also need to have a specific carve out for Indigenous data sovereignty, and I'll mention that in the next slide, based on some guidance that we've been receiving. Disability status and country of birth, including citizenship and postal code of household. Language ability is critically important. So language of training, we say you could have that on enhanced, but what is absolutely core is language ability, your ability to provide services in a language, or that you are providing services in that language. Language preference, which is the way a lot of organizations collect data, would be sort of in an enhanced module. But language ability, again, really, really critically important. Lots of data that we have in our minimum data standard to support that. Okay, so as I mentioned, we are seeking Indigenous-led guidance on the element around Indigenous identity. Angela Mashford Pringle is a co-investigator on the project, and she is leading this initiative. We had early discussions with the First Nations Information Governance Center, with the director, and to align with OCAP principles. The project really was beyond what OCAP principles cover, and it's also really important that that only addresses First Nations. So there was a lot of interest in this project. We have had follow-up discussions with the National Council of Indigenous Midwives, the Indigenous Physicians Association of Canada, the Indigenous Pharmacy Professionals of Canada, and the Canadian Indigenous Nurses Association. And some of the considerations is that we are really going to need to have Indigenous-led guidance to tease apart data collection, data verification, data stewardship, and knowledge mobilization based on the data that are collected. There are promising practices that each of the organizations that we've had discussions with have suggested, but there will be an Indigenous-led gathering in the fall of 2024 to develop policy and guidance, but also seeking to establish data infrastructure that enables the respecting of Indigenous data sovereignty by Indigenous communities and Indigenous organizations. So please stay tuned for that. So what I'd like to do now is to get some feedback from our demonstration project partners in regards to implementation and other considerations about the data elements, and that's going to prime you for conversations that we're going to have in the breakout. We do want you to consider becoming a demonstration project partner, and you can talk to our demonstration project partners to see like how onerous or not onerous that is. It would enable you to have access to the data elements and to provide us with feedback on those so that it becomes part of the minimum data standard. How we might want to refine questions or add questions, refine response categories, and really the next steps where we can go from here. And just before I break to pass over to Kelly and then to Adam, I really want you to know that any type of organization can consider adopting this enhanced health workforce minimum data standard. It could be by provincial territorial governments, unions, professional associations, employers, data custodians, educators, and regulatory authorities. So we're going to hear from two consortia of regulatory authorities, but everybody else can adopt this minimum data standard and collect data from your members and registrants in alignment with that data standard. And any type of data standardization would enable us to really answer much more broader set of questions.